Kenza, okay, we got that going. So for those of you who don't know me, I am Rhea Markowitz, and I'm from the Georgia Cancer Center, and I'm part of the hub team of our TeleDerm project. Dr. Doug Patton and I will be co-facilitating today's discussion as we usually do. Um, and I'd like all attendees to put their screens on gallery and have your cameras running if you can. Some people may have bandwidth problems, but try and have your cameras on when we have our discussion so we can see each other. So let's see. I would like to remind you all about our wonderful TeleDerm website. Kenza, next slide should be there. So here is our website. There is a lot of great information on that website. So when you're bored and want to learn more dermatology, you can log on. There are recordings of almost all past TeleECHO sessions that you can go back and watch at your leisure. And there is also a series of training videos that you can watch. And if you hit the correct button, you can get CME credit for watching those training videos, not watching the past TeleECHOs, but for the training videos. There are two ways to look at the training videos. One is just looking at them, and the other is for CME credit. It's obvious on the website, and there are articles and lots of good information there. So we encourage you to take a look when you're able to. So let's see. I want to welcome all of our participants today. I know we have PCPs from the East Georgia Healthcare Centers, EGHC, who are participating in our clinical arm, and PCPs from other rural clinics as well around the state. And we have residents and faculty from the MCG Family Medicine Department here, and some of whom are also participating in the clinical arm. We have people from our Department of Dermatology, Dr. Davis, Dr. Rabinovitz, Dr. Buchanan, our speaker, Dr. Riley. There are some MCG medical students probably. And as I said, Kenza and I are at the controls, and Brenda is not here today. We may have people who are attending for the first time, and we welcome you and hope that you will come back. We generally meet on the first Monday of the month at 4:00 as today. So here is today's agenda. We start out with some introductions, which we just did. Dr. Christopher Riley will be doing our didactic presentation today. Dr. Riley is an assistant professor in the Department of Dermatology and a fairly new faculty member. So we welcome him. We will have a case presentation by a third-year medical student, Katie Daly, so she'll speak after Dr. Riley, and then we will wrap it. We'll have a discussion. We'll wrap things up and have announcements and so forth. So at this point, let's see. Remember to everyone, please go into the chat and put your name, your affiliation to whatever clinic you are, and your title, and most importantly, your email address. We need to have that for our ECHO records. And now I will introduce Dr. Doug Patton to you. And Doug is the Dean of the Southwest Georgia Regional Campus, but he's on campus here in Augusta today. and he's been a rural physician most of his career, and he will continue with the program for a while. Thank you, Doug.
Thank you, Rhea. It's a pleasure to be here today. It's actually fun to be in Augusta, doing this. I'm coming from the conference room on the first floor of the beautiful Harrison building today. So, um, if we could, let's see, are those slides up? Yeah, the normal ones. If we could go ahead and have those slides, the normal slides that we go through. I'm not seeing them.
They're there. You
Uh,
want,
let me let me look. There, no, I see you. I don't see the slides.
you don't see the TeleECHO TeleDerm session slide up?
I don't. I saw it earlier. I saw it on Katie's screen when she was sharing it. Hang on. Let me see if I'm not doing something right here. There we go. It's there. It was
Okay.
there all along. It's just there's a different tab for it or some reason. Um,
Okay.
learning something new about Zoom every time I do this. So, yeah. So this is our motto: is moving knowledge instead of people, and that's what ECHO stands for. These sessions are meant to improve knowledge through the use of telecommunications to teach about teledermoscopy and teledermatology. Our goal here is to upskill people who are practicing at the local level and to be able to use these distance learning approaches so that we can address health disparities, particularly dermatologic health disparities faced by people, particularly in rural areas of the state. Next slide, please. So these are educational sessions. They're not clinical sessions. Please be mindful not to share PHI. They are recorded, and you're consenting to being recorded by staying on the meeting itself. There will be information at the end of the session about CME and CNE. There's also ways to connect back through the teledermatology website that Rhea spoke about. So if you have questions, you can email teledermatology@augusta.edu. Next slide, please. And we do collect data, as I mentioned earlier, about names and sign-ins and things like that. That's just part of it. But we cross-match that with the registration data so that we know who's attending. We also use this to get feedback on how things went, how we can make improvements, and also topics for new sessions going forward. Next slide, please. So just the general Zoom reminders. And again, I'm not one to speak because I didn't have it clicked up where I could even see the presentation, but um, type into the chat if you have questions anytime. You can raise your electronic hand by finding that on the icon buttons on the bottom. If you really need to break into something because you have a burning question or you need clarification, just open your mic and speak up. Please introduce yourself when you do that, anytime you speak, and do that. We'd like to have your cameras on if possible, so that we can see everybody, and gallery view works well for that. But we do recognize, especially in some of the smaller community settings, that bandwidth is a challenge and you may not be able to keep your camera on all the time. Again, the chat's probably the best way, especially today, if you're having technical issues, just to let us know that we need to be doing something different. So let's see, next slide. I think that's it for me. And what I'd like to do at this time is welcome Dr. Chris Riley, again, as Assistant Professor of MCG Department of Dermatology. Dr. Riley's rocking his Augusta University Dean's Green Polo today, so he's all in, and we appreciate you being here, Dr. Riley, and look forward to hearing your presentation. So I'm gonna let you take it away.
Thank you. Let's make sure the share screen's working right. I guess you're ready for me, right?
Yes, sir.
Am I on the right
You are
side?
you're,
Yeah.
you're looking good, sir. You're in
Perfect.
presentation mode and everything, so it's
All right.
perfect.
Well, it's a pleasure to be here today. My name is Christopher Riley. I've been here since August, but I've been in Augusta for almost 5 years now. I did the Army HPSV scholarship, so after residency, I was stationed here at Fort Gordon, and then separated from the military last summer. And so here I am. I've really enjoyed the last 8 months so far. Dr. Davis, the team, the residents have all been great to work with. And so I've really enjoyed it. And again, I'm happy to be here. I don't have any disclosures. What we'll be talking about today is going over allergic contact dermatitis, talking about the pathogenesis, just kind of recognizing some basic clinical features, and also talking about the methodology for patch testing to make the diagnosis when it's in question. And then if we have the time, review just some common causes and some cool pictures of allergic contact dermatitis. So first of all, just briefly, what is contact dermatitis? Well, it's when the skin comes into contact with an external agent, and it can cause various adverse events that include contact dermatitis, which is generally broken up into two different types, either an irritant contact dermatitis or an allergic contact dermatitis.
Your screen has two slides on it, I think. One's on top of the other.
Yeah, because okay.
There you go.
I didn't do anything, but are we good now?
Yep.
Okay. Well, irritant contact dermatitis is by far the more common, which is not going to be the focus of the discussion today, but it's when the skin comes into contact with something that causes a direct toxic reaction to the skin, which damages the skin barrier. It is not an allergy, so any pre-sensitization is not required. And everyone is potentially susceptible to an irritant contact dermatitis based on either the type or frequency of the exposure. Common causes include water, urine, saliva, harsh soaps, detergents, and acids. In contrast to that, we're going to focus on allergic contact dermatitis. I will say ACD probably many times today, but it is a delayed type hypersensitivity reaction that is caused when the skin comes into contact with a chemical to which an individual has already been sensitized. The responses to the skin are dependent to the particular chemical, the duration, the nature of the contact, and the individual's host susceptibility. The chemicals can cause a contact dermatitis that they can be found in jewelry, personal care products, plants, topical medications, including topical steroids, which we'll talk about later on, clothing, home remedies, as well as hundreds or thousands of other chemicals that individuals may come into contact with every day at work, during their hobbies, or in contact even with another individual. Here is just a schematic of the pathogenesis of allergic contact dermatitis. Generally speaking, it, like I said, is a delayed type hypersensitivity response. It's allergen-specific reaction that requires prior sensitization, like I said before. It involves an initial phase of sensitization when the patient first comes into contact with a chemical, which penetrates the skin and elicits a cascade of events that results in this sensitization. And then when there is re-exposure of the skin to the chemical, there is an antigen presentation of the chemical to already primed T cells, causing a release of cytokines and other factors that result in the clinical picture of eczema. And then once sensitized, all that's needed to elicit this reaction is a contact with the concentration of the chemical, even in very low concentrations, to cause the effect. ACD can affect anybody from all walks of life. It can affect the old, the young, and all races, both sexes. Differences between sexes can be seen, and generally based on various exposure patterns. For example, nickel allergies or gold allergies might be more common in people who wear jewelry more often. Occupations and hobbies also play an important role, so you certainly can see some very different specific allergens or contact dermatitis in various occupations. So allergens, and then as we'll get to later on, like the types of patch testing that you can consider can differ from person to person, occupation to occupation, and probably more importantly, region to region. For example, there are certain things that different governmental legislations may exclude certain products from being used in various products. For instance, there's something called Quaternium 15, which is a cosmetic preservative that is often used in the United States, but was banned in the European Union several years ago. So that might not be something that's tested on the European panels. That is still tested here. Even in different, even more regional, local differences, some allergens can increase in clinical importance over time, while others decrease due to various usage patterns. And also, new allergens are continuously being introduced into our environment. Both types of contact dermatitis, especially the chronic forms, can end up taking on a similar clinical appearance. The classic picture of a contact dermatitis is a type of eczema that is characterized by a well-demarcated red or erythematous vesicular or even like a scaly patch or plaque that often has a very well-defined margin corresponding to the area that it comes into contact with the skin. The distribution can be linear, such as when like a leaf or a branch is rubbed against the skin, or localized to the site where there has been contact with the offending agent. For example, like a hand dermatitis caused by ACD to epoxy resin, or a foot dermatitis caused by a component of shoes. Because different types of contact dermatitis like ICD or ACD or other underlying chronic skin conditions can be very difficult to discern clinically, patch testing can be helpful to identify the cause. And again, we're going to be talking about that more later on. Also, that's important is that for a clinician to be able to diagnose and treat it adequately, the history and physical can also be very helpful, which we'll get into as well. While also another note is, while we talked about like having a very well demarcated eczematous type rash where a contact allergen comes into the skin, it's also important to know that you can have this very patchy or diffuse distribution depending on the nature of the causative allergen. For instance, if somebody's allergic to something in a body wash or a shampoo that can be applied to the body more diffusely, it can cause a more patchy or diffuse rash. Acute contact dermatitis typically is characterized by more brightly red, blistering, weeping, swollen plaques, where chronic contact dermatitis typically is over time, you can see thickening or lichenification of the skin, and it becomes scaly over time due to the chronicity, as well as likely like frequent rubbing or scratching of the skin over time. Here are a few examples of acute allergic contact dermatitis. Again, it's very brightly red. You can, picture some, inflammation and swelling of the underlying skin on the left here. This was an acute contact dermatitis that was in a toddler who was exposed to the application of neomycin topical antibiotic ointment. And on the right-hand side, you can see this like these streaks of redness and vesiculation that was caused by exposure to poison ivy. You can imagine this person is, out in the woods or in the brush or in the yard, and it's streaking against their skin, causing this sort of picture. Here are a few examples of a more chronic allergic contact dermatitis. While it's still red, it's less acutely red. There's no active vesiculation or blister formation. The chronicity and or the frequent scratching, itching and scratching of the areas has led to scaling, thickening, or lichenification of the skin. On the left, this was caused by chronic exposure to leather products within the shoes. And on the right, it's a chronic hand eczema due to epoxy resin on the hands. Here is a side-by-side picture in a similar distribution. On the left, again, you see a more acute red with small little vesicles or pseudovesicles in the skin there, indicating a more acute allergic contact dermatitis that was developed within a few days of wearing shoes. And on the right, you see more of a chronic exposure with the thickening, scaling, and dyspigmentation of the skin from leather that was found in the shoes of this individual wearing them over a long period of time. Here's an example from our main textbook in dermatology that shows various patterns. Just again, this is not all inclusive. This only lists 4 when there's thousands of different allergens. On the top left, you see nickel. Thinking about where jewelry is worn in the ears, on the rings, bracelets, watches, etc. Potentially seeing around the ear or the cheeks where people are holding a phone or other electronic device up against their face. You can see it potentially on the thighs from laptop computers or things that are in their pockets. On the right, you can see rubber products, whether it be CPAP mask, elastic inserts within clothing, gloves, neoprene and knee braces or shin guards, or rubber in shoes. On the bottom left, you can see in various dyes typically found in textiles and clothing, which can really affect many places on the body where it may come into contact with the skin. It can be more localized, with a textile or like dye dermatitis, where you maybe have very tightly fitting clothes, like against the rubber, or with like sweat and moisture, or potentially more widespread. And on the right, MSI is a specific type of preservative that's found in numerous different skincare products. It seems to be decreasing over time, but it still can be found, where you can see it almost anywhere, depending on the type of products that's being used, if it has this potential allergen within it. And like we were alluding to before, this is eczema. It's red, itchy, scaly skin. So there's many different things that could be on the differential dermatitis, which we've already talked about. An irritant contact dermatitis. Other common ones would be like atopic dermatitis, stasis dermatitis, seborrheic dermatitis, psoriasis. Common things being common tinea. For a more widespread eruption, you may be thinking of like a cutaneous lymphoma or something else. So you have to think about like what is common to this area. Does somebody have pink scaly plaques in their scalp, on the extensor knees, the extensor elbows? Are they complaining of joint pain? Well, perhaps that's the history and physical are leading you to psoriasis. Do they have the tendency for involvement in the antecubital fossa or behind the knees? Do they have a history of asthma, family history of eczema, maybe childhood eczema? That could lead you to atopic dermatitis. Do they have the typical greasy scaling in the eyebrows, in the corners of the nose, in the ears, and in the scalp that may suggest seborrheic dermatitis? So those are all the things that we're thinking of when we're trying to put the story together of what they have. It's also very important to note that chronic dermatoses can also be multifactorial. People with all of these different clinical presentations, they may have had secondary impetiginization, like a secondary staph infection, have been using topical antibiotics on their skin, or they're using different moisturizers or skincare products that aren't fragrance free or hyperallergenic, and then their skin barriers broken down from these chronic conditions that may make them more susceptible to an allergic contact dermatitis that could develop on top of one of these chronic skin conditions. So certainly multifactorial allergic contact dermatitis is often seen. This is just an example about what we can consider with a type of a localized form of dermatitis. So here, let's consider like the eyelids. There are certainly many culprits that would be considered for an eyelid eczema or an eyelid dermatitis. Internal or endogenous considerations, atopic dermatitis, you'll frequently see this thickening or lichenification of the skin due to the chronicity of it over time. Seborrheic dermatitis, like I talked about, you may see like this greasy red patches or plaques in the eyelids or the creases of the nose, the ears, or the scalp, which could lead you to think of that as a cause. Ocular rosacea can affect the eyes, and it typically affects the lid margins, and you may see redness, bumps, or papules or pustules across the cheeks that are suggestive of rosacea, or even not even missing autoimmune conditions such as dermatomyositis that can often cause erythema and swelling of the eyelids. But then when you think about allergic contact dermatitis, then there are various different allergens that may be causing an outside in or an exogenous contact dermatitis. Fragrances, various preservatives found in numerous different skincare products, application of topical antibiotics to the skin of the eyes, individuals that are wearing gold or using various things that are found within artificial nails or nail polishes. While it might not affect the thick, resistant skin of the fingertips, if you're touching your face like we all do, probably more than we think we do, on the eyelids can certainly cause an eyelid dermatitis where it may be less likely to in other areas. So that's just an example of like a chronic eyelid dermatitis and like the thought process that can go into kind of teasing out what may be causing it. So you have to take that approach with any patient presenting with an acute or chronic rash. So that kind of goes into the importance of the history and physical examination when it comes in to determining the cause of allergic contact dermatitis. Many times what we'll also be recommending when we see somebody that could have a type of eczema, various avoidance measures. So we may be recommending skincare techniques that are inherently avoiding common allergens, and just discuss our routine gentle skincare practices using fragrance-free hypoallergenic soap in the shower and laundry detergents in their skin, and moisturizing the skin well to keep the skin barrier healthy and hydrated with a fragrance-free or hypoallergenic products. Sometimes if a patch testing, which again we'll get into in just a second, isn't feasible for a patient, maybe they live very far away from a practice that offers patch testing, or you suspect maybe one or few products may be causing a reaction, we may discuss something called a repeat open application test or a ROAT test. This is when you would recommend using a suspected product, as its intended use. So if it's a moisturizing cream, you'd have them put it on that way. If it's a soap, you may have it, wash that area body that's unaffected in a way that they may be using it as its natural intention, and you want to use it on an area of the skin that's not typically involved. Oftentimes, like the inside of the forearm, arm, or crease of the elbow, you'll have them apply it there, assuming they have no rash there, for a week or two, and see if it elicits a rash. While it can be helpful determining if a certain product may be causing it, the one downside is you're not determining what specific ingredient within that product is causing the rash. So that brings us into patch testing. So many times the clinical picture and the history are not sufficient to diagnose the specific entity or the cause of allergen, so patch testing might be necessary. Sorry, I had to get my cursor there. I couldn't find it. So it's a deceptively simple procedure that's done in the office. It entails placing potential allergens on uninvolved skin, typically the back, and trying to reproduce a localized dermatitis that's in a specific area that was in contact with the skin with that allergen. And then if it's positive, well, that person is allergic to that allergen or that chemical. However, deciding when to patch test, what to test, and how to determine if a positive patch test is actually clinically relevant certainly takes a lot of experience. One thing I want to point out is that patch testing is often confused, with patients or clinicians with skin prick testing or serum testing for IgE-mediated hypersensitivity reactions. So just note that they are not the same thing. With a skin prick testing, the allergen is introduced to the skin via the skin prick. It cross-links with IgE-mediated antibodies bound to mast cells and causes rapid degranulation and release of histamine and other inflammatory mediators, often within only 15 or 20 minutes. This produces the visible wheal and flare reaction, or like a hive. And then serum IgE testing uses blood samples to detect the same allergen-specific IgE antibody-mediated response through enzymatic assays. So these are more used to diagnose like allergic rhinitis, asthma, food allergies, and insect venom allergies, and certain drugs that cause allergies that cause these immediate reactions like anaphylaxis or hive. So, much different than patch testing, which we're trying to elicit this delayed type hypersensitivity reaction. I think in trying to conserve our time here, this just looks into the various different, by all means, this is not all inclusive, but some sort of common places and common allergens. Linear streaks on extremities, outdoor activity. We're thinking poison ivy, oak, or sumac. Somebody may come in and they're a florist and they have a chronic fingertip dermatitis. You want to think of their flowers maybe causing the ACD, with tulips being the most common. With the scalp, while it's often resistant to allergens due to the thickness of the skin, hair products, dyes, perms, rinse-off products are common. Perioral or intraoral dermatitis, flavorings, foods, cosmetics, sunscreens. Like I alluded to before, periocular or peri-eyelid dermatitis, you want to think of things that may commonly be found on the hands or the nails. Also cosmetics, eyelashes, adhesives, mascara, eyeshadow. Again, gold rings on the finger or other metals. Lips commonly cause allergens would be phthalates, dyes, sunscreens, propolis, which is found in beeswax. Think of Burt's beeswax, applying it to the lips there. Earlobes, nickels, golds, other metals. Neck, fragrances are common. The wrist, you want to think about chromate, which is in leathers on a watch band. Rubber, nickel, gold, also metal, jewelry, watch bands. Adhesives. Although most tape reactions are actually irritant contact dermatitis rather than true sensitizing allergic contact dermatitis, but rubbers, resins, and acrylates are often the causative agents in adhesive contact dermatitis. Hands, you think about gloves, latex, rubber, acrylates. Clothing dermatitis, it can be widespread. It often spares actually in the skin folds, like the vault of the axilla, but accentuated where clothes fit tightly, like around waistbands, etc. In this, you think of like anti-wrinkle or stain products like formaldehyde or formaldehyde releasers, various dyes or rubbers. You can keep going on and on, but I think we'll keep going ahead for now. So patch testing, it's been around for over 100 years, and over time, it's been further developed, and we've developed standardized allergens, testing devices, and protocols, as well as numerous different series of testings that we do. Prior to the application of the patch test, again, you want to think about those stereotypical exposures or something that the history and physical can elucidate what may have caused it. The patches are typically placed on the back, so it's important to make sure that they don't have like an active dermatitis, eczema, or sunburn on the back prior to patch testing. Also, it's best to avoid like topical therapies for eczema, psoriasis, etc. on the back prior to patch testing. We'll get into this a little bit later, though, about what you want to think about with systemic immunosuppression. There are various panels for patch testing. The True Test is a pre-made kit that tests for 35 allergens. It's very easy to obtain and use because it's pre-made. However, it can often miss many allergens because you're only limiting yourself to 35 allergens. And upwards of 76% more positive reactions can be seen with a more extensive panel. There are numerous baseline or extended panels for testing, and these are the ones that can vary by region or country. There are several North American baseline series that range from between the 60s to 80s within the number of allergens that they use, and this is often employed. But if if an individual's occupation, hobbies, or specific exposures are very much geared towards or suggest like a particular hobby or set of chemicals that could be causing it, there are very, very, very specific panels that can be used to try to tease that out. Metal panels, cosmetic panels, dentistry, floral hairdresser, and many, many other ones. Patient education is important. You'll need to, they need to know that 3 days or 3 visits over 5 days is the minimum expectations. The patches are placed on Monday. They're left in place for 48 hours. So they'll come back on Wednesday. Patches are removed, and there's initial reading by a dermatologist. And then on the final reading, because some reactions are delayed, which will be done on Friday. Also, there are a few allergens that can cause even a delayed reading beyond Friday. So depending on your clinical suspicion, you may have them come back the following Monday, or at least have a patient, family member, or loved one, review the back for a new spot, take photos, etc. If there are a lot of hairs on the back, they may need to be cut, shaved, or trimmed beforehand. Or if somebody has very greasy, oily skin, you may need to degrease with like alcohol or another mild solvent. Also, let the patient know itching and discomfort are to be expected, and they really shouldn't shower, at least get the back wet for that 5-day period. So that can be limiting. Just a brief note on, many patients, they have eczema, psoriasis. They may be on topical medications. They may be on Dupixent, getting phototherapy, on steroids, or on medications for their psoriasis. So, how does it affect that? This is a recent updated expert opinion providing a guideline for how we should consider this. First of all, on the left-hand side, when you see topical steroids, it doesn't preclude a patient from using topical steroids elsewhere, but it's recommending, based on the potency of what you're using, to try to, withholding it for 7 to 14 days around the biopsy site, or the patch test site that you're treating around that time. But really, honestly, they should really be clear of skin and active dermatitis in that area where you're patch testing, so the reactions are helpful. There's also in the middle here, you see recommendations for various systemic therapies. The most common thing that we're probably seeing are people on oral steroids like prednisone or people with eczema that are on Dupixent. So typically for systemic steroids, depending on who you read, you want them not on steroids at all would be optimal, but less than 10 or 20 milligrams a day of systemic steroids before patch testing. And if possible, potentially holding the biologic therapy like Dupixent for 2 weeks beforehand, although there's some differing opinions on that. As you can see here on the far right, you can still potentially consider continuing a biologic like Dupixent. It can be performed, but biologics may selectively impact the patch test results of certain allergens. So in our clinic, we offer an extended panel called the American Core Baseline Series, which has tests for 88 different allergens. We also have a metal patch test panel. These do not come pre-made. Our nurses make this individually before a patient comes in or when they come in on Monday for their patch test reading. The entire process for the nurse to make and apply the patch test takes about half an hour. As you can see here, you have several syringes that are labeled 1 through 88, which corresponds to a very specific well that's placed on the back. And on the top right corner, you can see that well or the wells within this rectangular patch labeled 1 through 10. That's where a small amount of each individual allergen is applied to the well, and then that well is then turned around and placed on their back. This is just an example of the list that we use. So you see 1 through 88 here. And as we go through and read the patches on their back, we can use this chart. Number 9 had a positive reaction. We'll mark it down and use that for the patient. Here on the left is after the patches are placed on the back, and then again further secured with additional tape to keep it in place, because as the tape moves, and it's not there where that skin marking pin is, very distinctly placing that patch so we know what number allergen is causing a positive reaction. If the patch testing moves between day 1 and 3, then the patch testing is probably not going to be very helpful. Here, as an example, you can see here on the first panel on the far left, there is a positive reaction at site number 9. On the third panel on the right-hand column, you see that that's a positive reaction. You may see some other like brown or pink or purple orange discoloration. Those are from dyes. Those are not positive reactions. As far as reading a patch test, you use grids that can easily determine the location of the allergen placement. There's an international grading scale ranging from negative reaction, doubtful, to extremely positive based on what it's showing. With a very faint redness, it just could be a doubtful or possible reaction. A positive reaction is typically felt by like palpable infiltration of the reaction into the skin, with a +1 reaction being like erythema with slight infiltration, a +2 reaction being erythema infiltration. You start to see this like vesicular or blister formation, and a +3 reaction is more extreme, bullous, ulcerative, as you can see there on the bottom left-hand corner there. Once a patient, we determine a positive patch test reactions, we'll give them an information sheet. Here it talks about what it's found in, things that you can use to avoid it, but also they're sent a safe list that can be, my wife's had these, they can be many, dozens and dozens of pages with hundreds and hundreds of different things that are safe to use. So as they're getting their skincare products, they can find those. I think this is where we get to that last part where if we had time, I would imagine at this point we probably need to move on. So I think this is probably a good stopping point.
Thank you, sir. That's very thorough and very interesting also. In the interest of time, I'm going to ask people if you have questions for Dr. Riley to go ahead and be putting those in the chat, and we'll go ahead with our case presentation, and then we'll come back and do questions at the very end for both Dr. Riley and for Katie Daly. So thank you, Dr. Riley. We appreciate you very much. At this time, I'm going to introduce Katie Daly, who is a third-year medical student at the Medical College of Georgia, and she is ready to share with us a case presentation.
Okay. Can everybody see the screen?
It's perfect, Katie. We see you. Thank you.
Awesome. Thanks, Dr. Riley, for getting us started. I'm going to present two cases today, so I'll try to go a little bit quick so we can get through both of them. But these are both patients that Dr. Riley saw recently that demonstrate our topic pretty well. So the first one was a patient who presented to the ER in the Children's Hospital, a multifactorial eczematous eruption in a 15-year-old. So he presented, has a history of asthma with this diffuse itchy rash that started on his hands and then spread to his arms, his trunk, his legs, and his lips. And he was also having this wet yellow discharge coming out of both of his nipples and his lips. He was actually having to blot his nipples with tissue paper because it was wet and going through his shirts. Didn't have any fevers or joint pain, but the rash all started after he had this upper respiratory infection 2 weeks before. So when he presented, he had already tried Neosporin, hydrocortisone cream. His PCP gave him amoxicillin for 5 days. That didn't help. And it also tried clindamycin and mupirocin, and none of these things were helping. He was just getting worse. So you can see him here on exam. He has this yellow crusting on his lips. He also had a similar yellow crusting on his nipples. He was also wheezing at the time of presentation, given his history of asthma. And you can see on the hands, he has that pseudovesicular reaction that Dr. Riley was talking about, where it's erythematous and it has these little bubbles that almost look like vesicles, but really they're eczematous. And then same thing on the hands here. This is where the rash started. You see these diffuse erythematous like plaques with that yellow crust overlying as well. And then here you can see it kind of extended to both of his arms as well. He had diffuse erythematous papules, and some of them were coalescing into plaques. So dermatology came and assessed, and the acute eczematous eruption with the pseudovesiculation was determined by an important feature of the history that he was applying Neosporin in certain areas, and his application of the Neosporin led to the worst reactions. So here on his hands, he had been applying Neosporin. He had also been applying it to his nipples and these spots on his arms that were the more irritated spots. So important to take a really good history and physical exam. Also, the more diffuse eruption was determined to be an id reaction. So this like secondary immunologic reaction to the initial eruption, where you can see these more diffuse erythematous papules. And then the yellow crusting on his lips, nipples, and hands was a secondary impetigo. So he got 2 days of cephalexin, then IV cefazolin, and then was transitioned to oral Keflex. He got mupirocin ointment 3 times a day, and then triamcinolone ointment as well, and then was told to avoid Neosporin. And you can see that at the follow-up, he looked significantly better. So that is our first case. The second case, this is a patch testing case. So this woman presented, she's a 69-year-old woman. She had a several-year history of this rash that kept coming up on her face and her neck. It was itchy. She said it would last for several days, but then go away. Sometimes it happened every other week. But when she presented, she had not had a flare in the last few months, which was tricky to figure out what something is when they are not actively flaring at the time of appointment. But she had tried triamcinolone on her neck in the past, and she said that helped. She'd also tried systemic steroids, which helped, but nothing on her face yet. A strong candidate for the potential exposure with her was a fragranced lotion that she applies to her face, but she said that she didn't think that it made her rash worse. And she also said that her rash got worse after taking the Shingrix vaccine, but she had had the rash before getting the vaccine. So these are, apologies for the quality, photos on her phone of times that she had eruptions, but you can see it's pretty well demarcated, erythematous all over her face and neck in this picture. And then in this one, you can almost see a scaling on her neck as well. So she got referred for patch testing, and she was given hydrocortisone 2.5 ointment to apply twice a day when it's flaring, as well as triamcinolone 0.1% ointment, and was told to follow the gentle skincare routine, avoid fragrance in her laundry, avoid fragrance on her face, and just practice that until her patch test, like Dr. Riley was mentioning. So here's what she looked like when she had her patches applied. And then at the first read, you can see she has at number 14, I don't know if y'all can see my cursor, positive for bisphenol epoxy, and then an iffy reaction to the one right below it for Carbamix. So this is after 48 hours. And then at her next read, you can see that 14 is still significantly positive, and another positive, number 6 for fragrance mix. some that were less significant were the Carbamix. It was kind of iffy, as well as these other two. So for her, we haven't been able to follow up yet. So hopefully she's doing better with her list of things to avoid and safe products, and her products in case of flare. But I was interested in looking into the epoxy resin because that's more of an occupational exposure, not as common, but there have been a lot of publications recently about this as an emerging allergen in women. It's really common in certain crafts, like making these coasters with epoxy and jewelry. So people may have exposure and not even know that they're exposed to epoxy. So I was also written about in someone who cosplays as a hobby and had like a handmade costume that they were wearing that was causing their exposure. It can be in games with children, anything like that. But in this patient, we think that the most clinically relevant one was probably the fragrance due to her fragranced cream that she was putting on her face. So we'll see how she does.
Thank you, Katie.
Thank
Those
you.
are interesting, very interesting cases. We appreciate you sharing those with us. And thank you, Dr. Riley, not only for your own presentation, but for helping Katie with this one as well. This should be of real interest to everyone who's in primary care because most of the time these patients don't show up at the children's hospital. They show up in somebody's office as a child or an adolescent or a full-grown adult. One of the things that, and I'll start off the question since I don't see anybody and I don't see any hands up at this.
Can I interrupt for a second, Doug?
Sure.
A lot of people, there were a number of people who came in late. If you could all write, if you haven't, write in the chat, identify yourself, where you're practicing, your department or whatever, and your email address while we're discussing things. Thank you.
Perfect. And ask a question while you're doing that. So
Right.
that
And
great.
Dr. Maynard has a question. Dr. Maynard's hand is raised.
Okay, Dr. Maynard.
Hi, I'm Brittany Manor. I'm from the Family Medicine program at Augusta University. I just had a quick question. Really great presentation. The first pediatric patient, I might have missed it, but do we know why he was putting the Neosporin on his hands and his nipples and all around those areas?
Sure. We assume that he probably had some sort of like viral exantha. There was something that predated the allergic contact dermatitis. He had his history of asthma. We suspected an underlying history of atopic dermatitis. There could have been a viral exanthum. But when we went in to see him for the consult, he was pretty specific about he put on the Neosporin to the hands, the nipples, and the lips. And then a couple days later, those areas specifically where he put on the Neosporin got a lot itchier and a lot redder. So there was a pre-existing rash that I think was certainly superimposed by this. So that was the main thing. And then when he'd come back to see us, it was mostly just kind of post-inflammatory discoloration with just a very little bit of mild residual eczema that was continuing to brew with the topical steroids and avoidance. So you're right. He absolutely had some sort of predating issue that seems to have resolved at follow-up.
Great question, Dr. Maynard, and thank you, Dr. Raleigh, for that answer. It calls to mind something for me that I think dermatologists are probably better than anybody else at making sure they look at the entire body. It's your job, it's part of what you do. But when someone comes in with a rash and it's in a visible area, it's probably really incumbent on us to make sure we ask and we welcome them to tell us where else might this be, because some of these areas might be embarrassing and they may not want to show, but it's important to get it as part of the history. All right. Any other questions right now? I'm looking to see if there's something. Nothing in the chat. I don't see any hands up. So let's talk about a healthcare related one of these. Oh, well, here we go. I think, oh, that wasn't a question. All right. Yeah, we believe you can write prescriptions. We have confidence in you. So before we run out of time, I would like for y'all to discuss latex allergies just a little bit, if you don't mind. That affects our patient. There are certain patient populations that are particularly prone to this, but certainly healthcare providers, and we got a whole room full of them now, a whole Zoom room full of them. So can we talk just a little bit about that? Dr. Riley, you got anything to share?
I think he's muted.
Yeah.
Yeah, he's muted. Go ahead and kick us off, Dr. Davis.
But latex allergies are a little bit more complicated.
Okay, I muted.
There he is.
My bad. That is latex allergies don't necessarily cause only an allergic contact dermatitis. So they can cause like respiratory distress, hives, anaphylaxis. It can be even done like contact urticaria. So latex is a interesting character to where it is not just as simple as it causing this type 4 mediated hypersensitivity reaction that causes just a pure eczema. It can, but it can also cause much more severe reactions, including, I guess, going back several years ago when you had like latex, like in rubber and our medical gloves, and it'd be in powders and such. There's a lot of cross reactivities with latex as well. So that's a loaded question, I guess. I don't know, Dr. Davis, unless you have any other quick tidbits about a latex allergy.
Yeah, we love to take care of allergic contact, but with latex, sometimes we use our allergy colleagues because they'll do RAS testing. You can do blood tests for latex allergies. It's just definitely much more complicated, and potentially much more dangerous, as Dr. Riley said.
Sure.
So we don't usually patch test. We may do RAS test, and if we're concerned, we send people to allergy.
Well, the question that just popped up in the chat is similar to a certain degree in that we may see latex allergies that are minor and they may be limited to topical, or it could be systemic and very, very severe. The same with penicillin type allergies. So the comment in the question is amoxicillin induced rash versus amoxicillin allergy, and how to, I guess, discern them and keep them from having to go to the big medical center.
Oh, I think that's another tough one too, because so many people have a history of like a penicillin or an amoxicillin allergy based on, a history that was provided decades ago, maybe by a parent or grandparent or something like that. And you don't even know if they had a true allergic reaction or anaphylaxis. Like somebody with an ear infection that was very likely viral gets treated with an amoxicillin and they have a viral exanthem rather than truly an amoxicillin type rash. Again, when you're running the risk of somebody potentially having, a severe allergic reaction, I think unfortunately our allergy colleagues do come into play a lot. And I think they have very specific algorithms too that can make it easier to determine who to test and when to test, but I do not know that off the top of my head, the algorithm that they use.
Very good. Thank you both. All right. In patients with darker skin tones, how might contact dermatitis present differently? And could subtle erythema be less visible?
Absolutely. So I think that's a very good point, is that the redness certainly can be much more subtle, and can definitely make it challenging and potentially delay the diagnosis. Also, people with darker skin tones, the residual like post-inflammatory hyperpigmentation or hypopigmentation that can happen can also potentially throw you off and make you consider other differentials. So that's certainly something that you need to keep in mind and take into consideration, like you were alluding to earlier, not being afraid to do that full body skin exam to really look for those other clues that can be telling and helpful.
Yeah, I will say too that dermoscopy is an amazing thing because you use your dermatoscope, you can really see some redness sometimes when at a distance you're just seeing darker skin. So dermoscopy can be helpful. You can take your thumb too and kind of push on the skin and you can see, it'll become more pale if there's a lot of erythema. So I think that the redness is there, it's just not quite as visible. And remember, allergic contact dermatitis is extremely itchy. So, I mean, that itch is very telling too. Because, just skin that's healed a little darker shouldn't be that itchy. Allergic contact dermatitis is very itchy, whereas irritant can be more of a burning sensation.
Okay, great. Well, we're about at time. I will just pass it off to Dr. Rabinovitz or Dr. Buchanan if they have anything to add, and we'll just give them a couple of seconds to see if they've thought of something, because we always appreciate them being on.
The only other thing was related to dermoscopy. You can actually distinguish nummular dermatitis from squamous cell carcinoma in situ. Both often are just pink scaly areas. With nummular dermatitis, though, it tends to be a little broader. You'll have this little yellowish scale crust, whereas with squamous cell carcinoma in situ, you'll see vessels as dots. So you can actually distinguish these. Not really related to a contact, but these chronic dermatitis can sometimes be helped by dermoscopy.
That's great. So we really need to be making sure we're all still focused on learning how to use the tools that are available to us. That's great. Thanks, Dr. Benovitz. All right. At this point, I'm going to turn it back over to Rhea Beth. And Rhea, if you'll close us out, please.
Okay, well, this was a great session. Oh yeah. I want to thank Dr. Riley and Katie for their presentations, especially Dr. Riley's slide of early on of the poison ivy. That would be me. That when I'm just slightly exposed, I have those welts from poison ivy. So our next session will be April 6th at 4 o'clock. We don't have a presenter yet, but we will have a presenter. And if any of you clinicians, the PCPs in our clinics, want to present a case, we would love to have you present any interesting case that you're seeing in the clinic. So, and the CME code is posted, and you text that to that number. Remember, you have to be signed up with MCG CME. And there is, I see a question about the link for where the past lectures are. Kenza, can you push forward to slide number, something like slide number 2, so they can get that, the link for our webpage?
Yes, I will have the link in the chat.
Okay,
shortly.
all right, that's great. That's great, because we are just about at the end of our time. So thank you all for being here. We had, I believe we had 47 people log on, which is just great. And I hope you all learned something, found it useful, and we'll be back with us on April 6th. And I see that our website is in the chat, so you can quickly grab that. And then the rest of you can sign off. Have a good evening. The TeleDerm team, please stay on for just a couple extra minutes to review. So thank you.